Good afternoon, everyone. Welcome. My name is Kylie Hall. I'm the Operations Director in the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure of introducing Dr. Walter Orenstein. He's going to be presenting the webinar, The Role of Vaccines in Eradicating and Eliminating Diseases. Dr. Orenstein is Professor Emeritus in the Emory School of Medicine. He was a former professor of medicine, epidemiology, global health, and pediatrics at Emory University, as well as the Associate Director of the Emory Vaccine Center and Director of the Emory Program on Vaccine Policy and Development. He has formerly served as Deputy Director for Immunization Programs at the Bill and Melinda Gates Foundation, where he focused on polio eradication, measles control, and improving routine immunization programs. He's also served as Director of the United States Immunization Program at the CDC, Assistant Surgeon General of the United States Public Health Service, and President of the National Foundation for Infectious Diseases. He is the past chair of the World Health Organization Polio Technical Consultative Group and served as the chair of the National Vaccine Advisory Committee. He is also currently a member of the World Health Organization's Strategic Advisory Group of Experts on Immunization for Polio, as well as Measles and Rubella Working Groups. His research focus has been on assessment of vaccine effectiveness in observational studies, methods to overcome vaccine hesitancy, ways to enhance uptake of recommended vaccines, and ways to facilitate polio eradication and sustain that eradication.
The opportunity to present on vaccines eradicating diseases. In other words, most of the vaccine preventable diseases are person-to-person spread. And if you break those chains, not only do you protect vaccinees, but you protect the community at large, including persons who can't be vaccinated or make a protective immune response. That I am complying with from an immunization research and efforts, and here just shows you what the disclosures are. I have been a consultant for vaccine manufacturers, CureVac, Securus, Merck, Sanofi, and Moderna, and the financial relationships have been mitigated. Okay, sorry. So my objectives today are to define what eradication and elimination are and the criteria that makes a disease eligible for elimination or eradication. Describe why disease surveillance, including whether cases are the result of vaccine failure to vaccinate, plays a critical role in disease eradication and elimination, and to try and make the case how investments by high-income countries to support efforts to eradicate or eliminate vaccine-preventable diseases in low-income countries benefit both low and high-income countries. What is the definition of eradication? The definition of eradication is the worldwide absence of a specific disease agent in nature as a result of deliberate control efforts that may be discontinued when the agent is judged no longer to present a significant risk from extrinsic sources. The only human disease ever eradicated is smallpox. Eradication means zero forever, and it's a gift of the generation that achieves it to every future generation. And this is just the example of what people call, I prefer the term community protection or community immunity. And what it means is when you have a transmitting case, that case can then come in contact with people and infect them and lead to an outbreak. When there's a high levels of immunity in the community through vaccine coverage, what you can see here is the likelihood of a transmitting case coming in contact with a susceptible individual is markedly reduced, and you can block transmission without having to get every single person immune. And who are the people protected? There are people who are not eligible for vaccination, who may be susceptible, for example, younger than the routine age. It's people with compromised immune systems who can't make a protective immune response. It's people who have allergies or medical contraindications to a vaccination. And it's people who are vaccinated but who didn't make an immune response. For example, the measles vaccine is extremely effective. 2 doses are 97% effective, but 3% are not protected. How are they protected? They're protected if not exposed. So even people who are vaccinated should advocate with people who are not vaccinated, not only for their own persons, these other persons, children of themselves, but for your own children in case your child is one of the 3%. There are 4 criteria in the potential biologic criteria for eradication. This is not an issue of resources and politics. This is biologic. 1, there must be an effective practical intervention that is available to interrupt transmission. Number 2 is there must be practical diagnostic tools to exist with sufficient sensitivity to detect levels of infection that can lead to transmission. There must be an absence of a non-reservoir for the pathogenic agent, and the organism does not amplify in the environment. For example, tetanus has a soil resource. Tetanus can never be eradicated because the organism Clostridium tetani is in soil. And 4th, there must be a demonstration in a large geographic area or region that shows transmission has been terminated with the intervention. Now, as I mentioned, eradicated is smallpox. This is a picture of a child with smallpox. In fact, when I worked in smallpox in India, I would use this picture in going door to door to ask people if they knew of a case of smallpox. There is about a 12-day incubation period, about a 4-day period of fever, and then you get the classic illness. And it was a very deadly illness. In the area I worked in India, it was about 30% case fatality ratio. But there were some very important points. It was 1, in contrast to measles, for example, the person didn't become contagious until they were very sick. And so it wasn't like they were walking around and infecting people, which made smallpox easier to control and eventually eradicate. Also interesting about smallpox is that's how we got the first vaccine. Edward Jenner in England noted that milkmaids who got cowpox lesions didn't get smallpox. And so he hypothesized that their immune response to cowpox also protected against smallpox. And in 1796, he vaccinated James Phipps, an 8-year-old. He didn't get institutional clearance for that. They didn't have them at the time. But and then exposed James Phipps to smallpox, and he didn't get smallpox, and that's how we got smallpox vaccine. And the word vaccine comes from vaca, or cow, and that's how and it became vaccine because of this cowpox effort. So what happened with smallpox is the original goal was to have mass vaccination. And then they found a shortage of vaccine. So they decided, well, until we get enough vaccine, let's do something called surveillance and containment or vaccination. Search for cases identify and vaccinate their contacts, provide a ring immunity. So basically, what I did in smallpox is when we found the case, put the case in the hut, we put a guard on the hut, and no one could go in unless they were vaccinated. Then we would identify who that person might have exposed, and we would do a census, and we would go back to those people until they accepted vaccination. And then we made some guesstimate of who, if this first ring got sick, who would they infect? The secondary ring, take a census of them and go to them. And so what we did is worked, and this became a way of enhancing things, and also because vaccinia was a very reactogenic vaccine, the smallpox vaccine, that because we were limiting vaccination to people who are at risk, we also decreased adverse events. So what made smallpox successful is, one, the disease was easy to diagnose. There were no carriers, no chronic transmitters. Almost all transmission was by droplets, which didn't stay in air very long. There was no transmission, virtually no transmission, until the patient became real sick. And you could get protection in giving vaccination as short as 3 to 4 days after exposure, given the long incubation period. So in summary, the clinical diagnosis was comparatively straightforward. The laboratory tests are definitive needed for eradication, but we need a laboratory for smallpox. The clinical syndrome was so distinct that I could teach a layperson to make the diagnosis. The major differential diagnosis was measles, was chickenpox rather, and spread was slow, and then transmission was almost traceable, always traceable to face-to-face contact. And so the question is, all of the following are practical necessary criteria for the biologic eligibility for eradication, except an effective practical intervention to interrupt transmission, practical diagnostic tools, absence of a non-human reservoir, funding, and political support. Okay, and this is a picture of the last smallpox case in Uttar Pradesh, India, India's largest state in north central India. And that's a picture of me in 1975, a few years ago. And what you can see here is this was a 7-month-old child. Her name was Shanti, daughter of Priyari Lal, and she died. And I was called to see her about an hour or two afterwards from an unusual complication of smallpox. She bled into her skin lesions, late hemorrhagic smallpox, but the last case of smallpox in India's largest state. And this is the last case of naturally occurring smallpox in the world. His name was Ali Mahmoud in Burqa, Somalia, in Africa. And he was not the last case. The last 2 cases were actually in the United Kingdom as a result of the leak, and they were occurring in 1978. So in 1980, smallpox was declared eradicated. And what are the benefits? In 1967, where the enhanced effort began, there were 34 countries that had smallpox cases. 31 were considered endemic. There were 217,000 cases reported, at an estimate that this was marked underreporting, 10 to 15 million, and 1.5 to 2 million deaths. For a total investment of $300 million, the estimated benefits were about $1 billion per year. A tremendous benefit to the world, but also to the U.S. In fact, David Sencer, who was director of the CDC in the 1960s, showed that there were 14.2 million persons vaccinated during the study period, 8.6 million revaccinations, 5.6 first. There were lots of complications, 238 required hospitalization, 9 died from their vaccine complications, 4 were permanently disabled, and the total costs to the country, including costs of quarantine, were estimated to be $150 million. That is now completely saved because of eradication. Now, there are continuing of services to improve health. One is just routine comprehensive health services, selective approaches to certain diseases, targeted programs like tuberculosis control, elimination, as we've been trying to do and have been successful to date, although it's in real different trouble right now, is measles, and then eradication, polio. So let me go over some of the definitions. Control of the disease incidence, prevalence, morbidity, and mortality to a locally acceptable level as a result of deliberate efforts. Continued intervention measures are required to maintain the reduction. And that's what we have with the vast majority of vaccine-preventable diseases. Elimination is the reduction to zero of the incidence of a specified disease in a defined geographic area as a result of deliberate efforts, but continued intervention is needed. This is not global, it's in a geographic area. And the definitions can be quite different. For example, for measles elimination, the goal is in our country that any measles case introduced does not lead to sustained transmission of that virus for over a year. So we could still get measles cases, but we can't have continued circulation. There are other definitions, such as neonatal tetanus elimination, which is basically a certain level of cases is compatible with elimination, not zero, but if you go above that, you lose your elimination status. So here is some of the definitions. You can see here for neonatal tetanus, it's no more than 1 case per 1,000 live births over a given year. Leprosy, 1 per 10,000. Hepatitis B, 90% reduction. So elimination has many different definitions as opposed to eradication, where it's zero forever. So again, eradication is permanent reduction to zero the worldwide incidence of infection caused by a specific agent, and intervention measures may no longer be needed. So my second question is, what was the first vaccine ever developed? Diphtheria toxoid, tetanus toxoid, smallpox vaccine, or polio vaccine? Please think about this and answer the question. Our most recent biggest effort in eradication is polio. This is what polio looked like in low and middle income countries. The polio virus destroys the anterior horn cells in the spinal cord, and these are the cells in the nerves that basically tell the muscles what to do. if, in fact, you destroy that, it's like cutting the wires to a light bulb. Your muscles can no longer contract. And so they become flaccid, and you have flaccid paralysis and muscular atrophy. If it paralyzes the muscles of respiration when it attacks the nerves in the brain that do that, then it could cause you not to be able to breathe, and that was the common cause of death from polio. And we showed how serious a problem polio was in low and middle income countries by doing maintenance surveys such as this. And polio was awful. We had thousands and thousands of cases of it in the United States each year. And this is a picture from the Rancho de los Amigos Hospital in California of a room full of people on better known as drinker respirators, because they couldn't breathe. And basically, they needed this for the rest of their lives because, again, these nerves could not regenerate. So why is polio eligible for vaccination? These are the criteria humans required for the pathogen lifestyle. And the poliovirus requires special receptors on human cells, and they're only on human cells with some in some high-level primates, but those are not big populations to sustain transmission. A second is sensitive and specific diagnostic tools. With smallpox, we didn't need it because the clinical syndrome was that specific, but with polio, what was done and is being done is to do surveillance for acute flaccid paralysis, to collect stools and send them to a laboratory and culture and use PCR to determine if poliovirus is there, and genetic sequencing to see if it's new in the community, it's related to something that was already there. In contrast to smallpox, where everything was clinical, less than 1% of cases of polio are paralytic, which makes it somewhat difficult. Was it an effective intervention? There were two effective interventions. The oral polio vaccine, which was a live attenuated virus, which was developed by Albert Sabin and became available in the 1960s, and the inactivated polio vaccine, an injectable kill vaccine developed by Jonas Salk and available since 1955. And we have gotten there, proof of principle. The wild polioviruses have been certified as eliminated in 4 of the 6 World Health Organization regions. And there are, in contrast to smallpox or variola, where there was only one virus, there are 3 polioviruses, types 1, 2, and 3, and types 2 and 3 have been certified as eradicated. So to show you what I was talking about, the transmission is generally oral, particularly fecal to oral, because that's where most of the shedding takes place. More than 70% of infections are without symptoms whatsoever. So if you came without a paralytic polio, you would often not know who gave it to you. About a quarter of the infections have a transit illness with fever, malaise, drowsiness, headache, nausea, vomiting, or constipation. And about 4%, 1 in 25, had aseptic meningitis, where they had this minor illness, this fever, malaise, and followed by real brain pain, and less than 1% had actual paralytic polio. The characteristics are it was asymmetric as opposed to Guillain-Barré syndrome, and it tended to first start in the central parts of your body and then proceed out. Your deep tendon reflexes were completely lost. You had the sensory part of it intact, but not the part, and that's why you got paralysis. The most common type was spinal, which is muscle paralysis, particularly of the limbs. Spinal bulbar include limb paralysis and muscle paralysis. And then bulbar was primarily breathing. And then paralysis was usually permanent because you killed the nerves. There could be some recovery if some inflammation, but if you didn't recover by the first 6 months, this was it forever. Now, the basic epidemiology, particularly in low-income countries, infected mostly children 6 to 24 months of age. The overall case fatality ratio was about 5%. It was most infectious immediately before and the 1 to 2 weeks after paralysis. And the problem is the virus was excreted for 3 to 6 weeks in the feces at high titer and 2 weeks in the saliva. The incubation period, generally the first symptoms was 3 to 6 days, and paralysis 7 to 21 days. And the lab diagnosis was very helpful, but the issue is that the gold standard is detection of virus from stool specimens, and that's the collection of stool specimens. This is the progress to date, and this is as of August the 5th. And what you can see here, there's been a 90% reduction in poliovirus cases since 1988 when this began. The only current wild poliovirus still circulating is type 1. Type 2 and type 3 have been eradicated globally. The oral vaccine is a potential problem because it's live attenuated virus. And unfortunately, it can cause polio itself. It can cause something called vaccine-associated polio, which occurs in about 4 to 5 million doses, and recipients are close contacts. And what has become a real problem, first recognized in 2000, is circulating vaccine-derived polioviruses, where polio vaccine given to a low immunity community circulates, mutates, and regains both the neurovirulence and the transmissibility properties of raw viruses and causes outbreaks. And we have some real problems with that. That's the most common cause of polio now, and particularly the type 2 component. We have 2 effective interventions, the Sabin vaccine, which is last weekend, and the inactivated Salk vaccine, which is killed. And this is a strategy. One is getting routine immunization, usually in a 4 or 5 dose schedule for children. And then national immunization days, at least a couple of times a year, vaccinating all children less than 5, going door to door with the oral polio vaccine. Third is careful surveillance, looking at acute flaccid paralysis surveillance, and then getting stools from them and looking for virus. And then what has really been very helpful is wastewater surveillance, sewage surveillance, doing environmental sampling. And when cases or virus are found, going on mass campaigns in that local area to try and terminate all chains of transmission. So some of the critical tools was disease surveillance. How do we know how good it is? And what was found is if you had an incidence rate of at least 2 per 100,000 non-polio AFP cases among children, that was generally considered you pick up polio cases if it were there. And then 80% of AFP cases investigated had at least 2 stools collected. Then what became important, as I mentioned, is environmental coverage, and then going over and looking how well people were getting vaccinated. assuring that people were getting vaccinated and that the vaccinators were doing their job. Some of the other things there that were done were ink marking on the kids who got vaccinated and then having independent monitors go in and just check how many in an area actually were vaccinated. And this just shows you how far we come. The whole effort really began in the Americas with the Pan American Health Association setting a goal to eradicate polio in the Americas by 1990. The World Health Assembly was so impressed that they established a goal for global eradication by 2000. The last case of wild virus polio in the Americas was in 1991 in Peru. The last outbreak of type 2 virus in the world, wild virus, was in Aligarh, India in 1999, and that's where the picture was of me that I showed you earlier. That was smallpox, not polio. The last out in 1999, the Western Pacific region, including Japan and China, was certified as totally polio-free. 2002, Europe. In 2012, the last case of type 3 in Nigeria, India, in 2014. And then what you can see here is in 2016, there was a decision to take type 2 out of the trivalent type 1, 2, 3 vaccine. Of course, it had been eradicated, and that's become a problem because we now see big problems with circulating vaccine-derived poliovirus, primarily type 2. And what you can see here in 2025 is 99 cases of wild poliovirus, all of them in only 2 countries, Pakistan and Afghanistan, whereas there have been 100 cases of CBTVs in many countries, primarily type 2, 97 of them, and some type 3, and this time, not any type 1, but there had been type 1s. And this just shows you the progress. In 1988, when this began, there were an estimated 350,000 cases of paralytic disease, 125 endemic countries. Again, in 2025, 99 wild poliovirus cases, and 25 in Afghanistan, 76 in Pakistan. Those are the only endemic countries. And this just shows you another. Here's Pakistan and Afghanistan, showing the time that has happened with them. And this is from non-polio sources. And you can see here, and this is from other countries around the world that were not endemic. So this is the big area that it's isolated in. And this just shows you the red dots, wild poliovirus, and this is in the last year. And you can see they're all in Pakistan and Afghanistan, but what you're seeing in the green dots is type 2 circulating vaccine-derived poliovirus. And in fact, we had a circulating vaccine-derived poliovirus type 2 in New York State in 2022. So it's clearly an interest to finally get rid of all the polio. And another thing that became very useful is, as I mentioned, environmental surveillance, wastewater or sewage surveillance. And you can see here in Pakistan that these are the cases of actual paralytic polio, but we could, by looking at wastewater surveillance, you could detect all these other cases. So while you might think polio is gone, this shows it's not, and it's become a very important tool. So type 2, again, was certified as eradicated in 2015, type 3 in 2019. And so which polioviruses have not been eradicated? Type 1, type 2, type 3, types 1 and 2, or types 2 and 3. So what about measles? Measles is a disease for immunization programs. It's highly contagious. It's most infectious of the vaccine preventable diseases. While there is a differential diagnosis, it's clinically distinctive in that it's a rash illness with fever as opposed to, for example, influenza or COVID. Virtually all cases are clinically compared as opposed to polio, where virtually hardly any of the cases are clinical impairment. There are good diagnostic tests. It's episodic in nature, and it does have substantial complications, including hospitalizations and deaths. The first measles vaccines in the United States were licensed in 1963, and John F. Kennedy, the uncle of RFK Jr., established our immunization program in 1962 with him signing the Vaccination Assistance Act. And so one of the things that was said is, why don't we try and eradicate measles? And there were 4 criteria: routine immunization of infants, immunization on school entry, surveillance, and epidemic control. And what they found is a greater than 90% reduction in cases by 1968, as opposed to millions in the pre-vaccine era. There was improved reporting. There was probably a massive reduction in 90%. And the funding was switched to rubella because there were real concerns. Rubella was a major cause of adverse events. And what you can see here is this is when the program began. Lots of dollars were put in the dashed lines. Dollars up, cases down. Cases down, dollars got suspended. They didn't use the dollars. Cases came up because coverage went up. People were born each year and they didn't have immune. Led to more funding. Funding went up, cases went down. Funding started coming down. Then we had efforts, and we had a presidential initiative finally, and that's the issue, is we need to, until a disease is eradicated, we need to continue the effort, because people arrive, just as if we stop vaccinating today, this minute, all children will have big outbreaks tomorrow. It will take time for susceptibles to accumulate. So the smallpox was eradicated with an outbreak control strategy, and maybe we could do that in the US. And what was learned is mandates made a big difference. The need for a continuous source of funding and surveillance was critical, as well as political leadership. And this is a study done by Phil Landrigan in Texarkana, Texas, back in the early 70s. And what you can see here is Arkansas had a law mandating immunization for school attendance. The Texas part of Texarkana did not. And look at this outbreak. Lots of cases there, no cases there. And then in Los Angeles County in 1977, there were 2 deaths, 3 encephalitis cases, multiple measles cases, sustained transmission, even though clinics were held in the schools. And Shirley Fannin, who was a director of acute communicable diseases in Los Angeles County, said, I'm going to throw your children out of school if they're not vaccinated by a certain date. And lo and behold, by the 2 months where she had clinics in the school and everything, there were about 50,000 kids who didn't have evidence of measles immunity, and she excluded 50,000 kids out of school. Many of them turned out to be vaccinated, just hadn't got the evidence in. But this became the standard way of controlling outbreaks, and it didn't take long to recognize we should be in the business of preventing outbreaks, not controlling them. And this just is an example of the effectiveness of mandates. 6 states that enacted the mandates eventually, and others, and the incidence of measles didn't really go down in these states, but went way down in those states. And that led to a presidential initiative to enact and enforce school mandates It led to another presidential initiative later to eliminate financing barriers, the Vaccines for Children program, and it led to the National Immunization Survey to measure coverage in a standard way. And this got adapted in the Clinton presidential initiative, and the state that was at the lowest level in the first National Immunization Survey was Michigan. The health office there used that to get lots of money from his state legislature since they were at the bottom and played a big role. So the lessons learned were strong scientific base, measurable goals, compare and contrast good performers, develop key partnerships to build the political base, and focus not only on vertical, but build the whole system. There are goals to eradicate which of the following diseases: measles, polio, or tetanus. So to end, there are critical issues in immunization program success. Understanding the epidemiology of the disease to be prevented, who transmitters, who's most seriously affected, should a universal immunization program be implemented in the first one, or targeted to more selective groups. Knowing the effectiveness and safety in populations for whom vaccine is recommended, having a surveillance system in place to determine if cases are the result of vaccine failure or failure to vaccinate. If vaccine failure, what is the reason? Problems with the cold chain, waning immunity, subpopulations with poor response, and take action based on what was needed, such as booster doses. If failure to vaccinate, then what is the problem? Is it hesitancy? Is it problems with access, such as financial barriers? Or is it people, the National Immunization Technical Advisory Group, the ACIP in our case, didn't recommend be vaccinated? Have an ongoing monitor in place to continue to answer the questions, measure vaccine effectiveness in observational studies when randomized studies are not ethical. Vaccine safety evaluation, look for adverse events, determine if they are causal characteristics. Is there persons you can identify and make vaccine a contraindication for them? If not, is the risk of the vaccine greater than the risk of the benefits, greater than the benefits outweigh the risk, and have a strong communication system to deliver the right messages by the right messengers through the right communications channels by key groups, public health and healthcare providers, media, the general public, and more. So eradication is extinction of disease. Elimination is stopping the spread within a defined geographic area. Surveillance is critical to help track progress because our goal isn't immunization, it's getting rid of the disease, identify outbreaks and the reasons for it. And global collaboration benefits everyone. If we were able to eliminate measles everywhere, we'd be having the resurgence we're having now. Thank you.
Dr. Ornstein, that was wonderful. Thank you so much for that awesome and wonderful presentation. Okay, so some questions for you, Dr. Ornstein. I have one for you maybe to get us started.
Sure.
So you played a pretty significant role in the eradication of smallpox. Can you just tell us, maybe what sticks out in your mind about some of your efforts in India and elsewhere? Can you just reflect on your role and what sticks out about that time period?
Yeah, what is really important is to get the political will and support. Sir Quadros, who was director of the immunization program of the Pan American Health Organization for many years, used to say the P in public health is politics. And it's really important to get that support. So in India, working with groups such as the pediatricians was very important to build confidence in what we were doing. And it was very, very helpful to bring in and develop coalitions of partners who were respected in the community, because there was always distrust and trying to counter that. And that was my first effort to deal with vaccine hesitancy, because Smallpox vaccine was extremely reactogenic, very unpleasant vaccine. And what I used to do when I'd been vaccinated is when we found a case in the village, we would gather the village around and I would vaccinate myself. The first time I got a whopping reaction with lymphangitis and lymphadenitis, but after that, nothing. But trying to find ways of countering this hesitancy and bringing in people who could be trusted. For example, in there were substantial communities of Muslims and Hindus, and sometimes they didn't trust each other. And bringing people around door to door in the same community was extremely important.
Yeah, that's wonderful. Thank you for that. All right. So my next question for you, this is kind of like a crystal ball question, Dr. Orenstein, but knowing what you know about, the situation globally and the time period and the political will, what would you say would be an ideal timeline and a possibility for eradicating the next disease, likely polio, but maybe even looking into the future, some of the diseases that you talked about? What could a timeline look like for eradicating the next disease?
That's a very good question and a very difficult answer, because my fear is we may be going backwards now with the U.S. coming out of WHO, ending the USAID, and ending funding for a number of these organizations. On the polio side, for example, the Gates Foundation is trying to step up, but I'm not sure it can cover the funding needs. And what we need is we need to purchase the vaccines, but we also need to invest in the delivery system. Vaccines don't give themselves. And in smallpox, we learned what we needed was this new vaccination approach. For polio, we recognize we need this mass vaccination approach. And we need to understand, how do we overcome resistance? How do we overcome hesitancy? Because there's so much distrust in the world. So at this point, I think it would be very difficult to start on eradicating a new disease. For example, measles meets the criteria for eradication. It requires human transmission. We have an effective intervention. We have got rid of it in a lot of places, or it's resurging now in the US. But I would be very hesitant until we can finish polio and again, get the political will to get the support to do this.
Yeah, absolutely. Another question. What have you found to be successful in helping parents and families feel more confident to get vaccinated?
I think what's very important is two things. One is anecdotes are persuasive than numbers. My boss for 13 years at the CDC, Alan Hinman, used to say, anecdata will always trump real data. The issue is to get anecdata that illustrate real data. Because when you have a successful prevention program, people don't realize they're getting any benefits. They don't see the threats as opposed to therapy. And so what's important is the stories. The second issue is, who do people trust? Study after study has shown that primary care providers are often the most trusted messengers, and trying to work with them to give them tools how they can answer parents' questions, for example, or deal with it or anticipate it so that they know how to do it. There are techniques called motivational interviewing, presumptive recommendations, things that are needed to try and overcome hesitancy. And again, trying to make the diagnosis. In the Clinton administration, we got a presidential initiative. We had a big resurgence of measles, and we found that the problem there is that parents couldn't pay for vaccines. And so they weren't getting vaccinated at their provider's office. They could get free vaccines in health department clinics, but it was a hassle to get there. and that led to the Vaccines for Children program. So we need to keep the science going. We need to find those messages, and we need to invest, in my opinion, in implementation science to determine what messages work and what does not. And for example, motivational interviewing is basically, you've raised a good question. I certainly understand it. Giving people who are hesitant credibility as opposed to saying, you're crazy, that the science doesn't support it. That's not the way to talk to someone who's hesitant. And just try to do that. And one of the things I think, when I was chair of the National Vaccine Advisory Committee, we had a recommendation to build confidence, a draft recommendation to support reimbursement to providers for vaccine counseling. And the insurer said, show me the data that makes a difference, because they were concerned about abuse of that code. And let's fund the research and see if it makes a difference, because a number of the pediatricians at the time said, we just don't have the time to spend in counseling and talking with parents who are hesitant. But I think we need to do that in order to look at what's happened. And again, surveillance is critical. What we found in the United States with measles is most of our cases in preschool children were failure to vaccinate. And most of our cases in school-age children were vaccine failure, because the contact rates and herd immunity threshold of school children was much higher. And so that led us to a 2-dose schedule in school children, and it led us to overcoming the barriers with the financing in the Vaccines for Children program.
I think we have time for one more question, and I think this question goes right along with the title of the webinar and vaccines' role in eliminating and eradicating diseases. Someone's asking, can a disease eradicate itself? To which I'm going to take to mean, can a disease be eradicated without something like vaccination? Could you address that, Dr. Ornstein?
I think that's theoretically possible. And there may be, I'd have to think more about it. But that a disease that it can eradicate itself would be one that has low transmission, low basic reproduction number, the ability to transmit, and high natural immunity, or et cetera. So it's possible. But the beauty of vaccines is that with most of the vaccines, 1 or 2 or a few doses give you lifetime protection. And so it's a lot easier than having to let's say, take a drug every day or something like that. And again, another big issue that we're having problems with now is this whole issue is, it's my body or my child's body. You can't interfere. And we need to find a way to try to explain to these people and encourage them that it's not only protecting you if you get vaccinated, but the community. And even if your child was vaccinated, there's a small percentage who might be protected. If your child is in that, then that child can be protected if they're not exposed, and that's when we have high levels of immunity in the community. But we need to find a way of what works. That's my guess. I don't know. I'm not aware that that's been tested yet.
Wonderful. Well, I want to say thank you again to Dr. Ornstein for joining us today and giving us a wonderful presentation. I learned a lot about this topic, and I hope everyone found it really insightful. Dr. Ornstein, thank you, and
Thank you very much.
rest of your day.
Thank you too. Thank you.